You stopped Ozempic. Maybe insurance ran out. Maybe the cost became unrealistic. Maybe the plan was always temporary. And the weight came back. Faster than you expected. More than felt fair. Not because you suddenly became lazy. Not because the medication failed. The real problem is that most people miss the most important window. And by the time they realize it, that window is already closed. The rebound is often decided before you stop, not after. This is not medical advice. Consult your doctor. That window is not after the regain starts, it is while the medication is still working. I'm Dr. Kim. If you understand this one point early enough, the rebound after stopping can be significantly less severe. When you stop Ozempic or any GLP-1 medication, appetite often returns fast, but your calorie needs stay lower because you now weigh less than before. That creates the trap. Hunger rises before your metabolic system is ready to defend the new weight. Most people know what to do in theory. The harder question is when to do it, and I will get to that. There are two levers that matter most, and both work best when you build them before the medication is gone. Sleep sits alongside them, and I will come back to it, because it is more metabolically relevant than most people treat it. Lever 1. Muscle mass. Muscle is metabolically active. The more of it you carry, the more calories your body burns at rest. This matters because after significant weight loss, your resting metabolic rate is already lower than before you started. If muscle loss happened during treatment, it is even lower than that. Here is the part that often goes unnoticed. Some studies suggest that a meaningful portion of total weight lost on GLP-1 treatment, in some cases between 25 and 40%, can come from lean mass rather than fat, depending on diet and activity level during treatment. That proportion matters because lean mass is what drives resting calorie burn. Losing it quietly during treatment means your baseline calorie burn drops further than the scale suggests. By the time you feel the problem, you are already behind it. Muscle loss during treatment tends to be silent. The scale keeps moving in the right direction, but the composition of what is being lost shifts in a way that only becomes apparent after stopping. This is why resistance training during treatment matters, not just after. People who do not train while on the medication often find that their total weight loss looks similar on paper to those who did, but their body composition and post-stop trajectory are meaningfully different. The number on the scale does not tell that story. Resistance training is the mechanism, not a bonus. 2 to 3 sessions per week is a practical starting point, and here is where most people quietly lose the advantage they spent months building. Lever 2. Protein intake. Protein does two things simultaneously that are directly relevant here. First, it blunts hunger more effectively than carbohydrates or fat, gram for gram. When the appetite suppression from Ozempic is gone, protein becomes one of the few dietary tools that partially fills that gap. Second, it supports muscle synthesis, particularly when combined with resistance training. What protein provides at the dietary level, resistance training converts into muscle. More muscle means your body burns more in the background. In practice, aim for roughly 25 to 30 grams of protein per meal. Chicken, fish, eggs, Greek yogurt, tofu, not as a supplement to the meal, as the anchor of it. One additional strategy worth applying. Eat protein first at each meal, before carbohydrates or fat. Studies suggest this sequence reduces post-meal glucose spikes and extends the satiety signal from that meal. When appetite suppression from the drug is gone, sequencing becomes one of the few tools that can meaningfully slow hunger between meals without adding calories. Here is the window most people miss, and the mistake that comes with it. While you are still on the medication, food noise is quieter, appetite is lower, and habits are easier to repeat. That is the easiest phase to build the routine that has to survive after the drug is gone. The mistake: most people wait until hunger comes back to start building those habits. By then, the biology is already pushing in the wrong direction. Most people start rebuilding too late, and then call it rebound. In clinical practice, this window can close faster than people expect. For some patients, appetite begins returning within days to weeks of stopping, not months. If you are currently on Ozempic or a similar medication, resistance training now, protein targets now, the pattern needs to be established before hunger returns. If you are approaching a planned stop, talk to your doctor before you do. Many clinicians prefer a structured transition rather than an abrupt stop. A gradual reduction gives time to test how appetite and habits respond before full support is removed. The weeks immediately after stopping are the highest risk period for rapid regain, and a structured transition keeps clinical oversight in place during that window. Part of what makes those first 2 to 4 weeks so critical is the hormone rebound. Ghrelin, the hormone that signals hunger, can rise sharply after stopping in many cases, while leptin, which signals fullness, can remain suppressed at the lower body weight. The result is a biological environment that pushes hard toward eating more before the body has adapted to its new baseline. This is not a willpower problem. It is a predictable physiological response. One specific warning: be careful about stopping during high stress periods, a job change, a major disruption, a stretch of poor sleep. Stress elevates cortisol, a hormone that drives hunger and promotes fat storage. If stopping is elective, the timing of that decision matters more than most people account for. But for many people, the stop has already happened. The weight is already moving back up. The question then shifts. The first question is whether restarting medication is appropriate for your situation. Current evidence frames obesity as a chronic metabolic disease, not a temporary condition to be treated and resolved. The relevant clinical question is not whether the medication worked. It is whether the reason for stopping was clinical or logistical, and whether those circumstances have changed. If cost or access was the barrier, the options may be broader than expected. Some clinicians use lower maintenance doses rather than a full therapeutic dose, not optimal, but enough to slow the hormonal rebound while other habits stabilize. If restarting is genuinely not an option right now, protect the 3 variables most likely to drift fast: protein intake, resistance training, and sleep. Sleep is not a lifestyle recommendation. It is a metabolic input. Even a few bad nights can raise hunger hormones and weaken satiety signaling. Add sustained stress on top, and that same hormone suppresses satiety, promotes fat storage, and degrades sleep quality further. A loop that amplifies from both directions. Address both as a single metabolic target. The drug creates the conditions, the habits close the deal. And the window to build those habits is not after the weight comes back. It is right now, while the medication is still working. Medicine simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.